to be here with Dr. Rupa Valdez. My name is Maya Sabatello. I'm an associate professor at the Center for Precision Medicine and Genomics and the Division of Ethics here at Columbia University, and I'm co-directing this seminar speaker on disability ethics, intersectionality, and AI/ML bias, which is co-sponsored by both my home departments as well as the Department of Biomedical Informatics. And we're so grateful to have the opportunity to have that meeting also in your weekly seminar speaker. So thank you. So the seminar speaker is funded by the National Human Genome Research Institute. It's part of an effort to engage in an interdisciplinary dialogue about the experience of people with disabilities in healthcare research, and society at large, and to think about how our different disciplines can interact, engage, and ultimately improve the technologies, the health outcomes, and so forth for people with disabilities. So for this purpose, we are inviting speakers to share their work and insight on issues and challenges that arise with regards to people with disabilities in medicine, big data, technologies, and emerging technologies. And I'm delighted to have Dr. Rupa Valdez here with us today. Just as a quick housekeeping note, this is a hybrid event, so some of us are here in the room, some of us are on the Zoom. We have a live captioner, and we post, and so if you want to have that captioning, just press the button on your end of the computer. The structure for our seminar is that the speaker presents for about 45 minutes and then followed by Q&A. And we invite you guys here, present here, as well as people on Zoom to engage in the conversation. If you're here, you can raise your hand. If you're on Zoom, you can post it and we can pick it up as well. Our next speaker for this specific seminar speakers is on Monday, April 8th at 12 p.m. I know your usual seminar is at 1, but this one will be at 12 p.m. And we will host Dr. Megan Hoffman, who will discuss how to engage clinicians and patients as experts when creating novel healthcare technologies. So please pencil it in as well. So now for the main reason we're here, Dr. Valdez is a professor in the School of Engineering and Applied Sciences and the School of Medicine at the university. She is also a core faculty member of Global Studies and the Disability Studies Initiative. She merges the disciplines of human factors engineering, health informatics, and cultural anthropology to understand and support the ways in which people manage health at home and in the community. Her research and teaching focus on health disparity populations, including populations that are racial and ethnic minorities, are of low socioeconomic status, and or are living with physical, sensory, or cognitive disabilities. Her work draws heavily on community engagement and has been supported by numerous funders, from NIH to NSF, the Agency for Healthcare Research and Quality, and the US Department of Agriculture, among others. She has testified before Congress on the topics of health equity for the disability community and received the Jack Croft Innovator Award from the Human Factors and Ergonomics Society for her pioneering work in creating and developing the subdiscipline of patient ergonomics. Dr. Valdez also serves on various board of directors related to people with disabilities and is journal editor for several leading journals, including the Journal of American Medical Informatics Association, Open. And on top of this, she is the funder and president of Blue Trunk Foundation, a nonprofit dedicated to making it easier for people with chronic health conditions, disabilities, and age-related conditions to travel. And she herself lives with multiple chronic health conditions and disabilities, which have and continue to influence her research, teaching, and advocacy. So today, Dr. Valdez will share with us some of her work with a talk titled Understanding the Disability Community, Community's Need for Communicating with Social and Caregiving Networks. And with no further ado, Rupa, the floor is yours. Great to have you here. Thank you.
Thanks, Maya. Thanks, everyone. So I do live with multiple chronic health conditions and disabilities, which is why I'm sitting instead of standing up there. And also for those of you on Zoom, I can't look at the screen for long periods of time, so I'll try to look your way once in a while, but I'm gonna get a little bit of a profile view. So I thought what I would do today is start out, as I like to do generally, and tell you a little bit about my own disciplinary journey, so you can get a little bit of a sense of where I'm coming from as we go into some of the work in particular. So as mentioned, I started out as a human. Well, I'll start talking while we.
Well,
Oh, maybe it's
Yeah,
it's not wireless.
You might need to like click on the screen once and then that
Maybe.
will let the screen.
So it's active. Yeah. There we go. We got it. We got it. Okay. All right. So I started out an undergraduate as a human factors engineer. And when I try to explain what human factors is, I'm guessing some of you might know, but I really think about it as a concept of alignment. So you might think about like an ergonomic chair, ergonomic scissors, right? And that's really about creating alignment with your physical body. I was really interested in alignment from a broader sense, and that's what I'll end up talking about today. But in terms of how do you create alignment between technologies that you're designing or even broader systems with people's everyday lives. So if you're looking at what somebody's daily routine looks like, what does it mean to create alignment there? Or what does somebody's community, we'll talk about caregiving networks and social context look like? How do you create alignment with the technologies we're designing from that broader perspective? I have these symbols of accessibility here, and they're the points in time where I developed my own chronic health conditions and disabilities. So my first time was when I was 19 years old. I developed multiple chronic health conditions. It took a very long time to get diagnosed. And for someone who was a very healthy, young adult teenager, for me, the process of spending a lot of time in healthcare facilities was very eye-opening for me. So I had never spent time in clinical settings. I had never experienced the frustration of a multiple year period of trying to get diagnosed. And I happened to be at the University of Wisconsin-Madison at a time when the people who were doing industrial engineering and human factors were really interested in the question of how can we apply these techniques in the context of healthcare. So as opposed to thinking about manufacturing settings where most of this work had been applied, how do we move into healthcare settings? And then it was also at Wisconsin at a time when health informatics, there was a movement from thinking about how do we design technologies to support physicians, right, and other health professionals, to what does it mean to actually create consumer health information technology? So you picture like lugging the big computers, right, into patients' homes and setting them up and trying to create care networks or social online health communities back then. And that was really focused around addiction treatment, and breast cancer was the space that we were working in. And so I like to say, this is where my head was at this time. And at the same time, I'm living with my own health conditions and feeling a lot of cognitive dissonance. So I'm getting certain recommendations in the healthcare space about how I should be changing my diet. And one of the recommendations I get, for example, is to not eat spicy food. Well, I'm a South Asian woman, so I grew up eating a lot of spicy food. And so I remember thinking, I think I know what is meant by this. But going home and having that conversation, I think my family's going to think about this very differently than what the clinician is asking me to do. And so based on that, and based on the fact that I was trying to spend a lot of people's homes and communities, I thought I really need to learn how to actually do this from a science perspective, right? In engineering, we're not trained about actually how to go into homes and communities and start thinking about these aspects of people's everyday lives in the context of design. So I like to say I wandered off engineering campus and I spent some time in cultural anthropology, really trying to learn how do we do all the qualitative work that can inform our design process. So I did some of the public health, and then starting towards the end of graduate school and then into my faculty position, started doing a lot of community engaged work, some of which I'll talk about now. It spans more than the work that I'm going to talk about today in the disability community, but that was with David Edmonds in the back here, who's accompanying me, and I'm going to call you out because I laugh that as a faculty, I felt like I also ended up doing a postdoc in some ways with him in terms of learning how to do community engagement work. Again, something that not trained in from an informatics perspective, or wasn't trained as an engineer in how to do that work well. And so at the beginning of my faculty position is also the time where I became, I say disabled again in some ways. So I became a wheelchair user. I had some other chronic health conditions that emerged and they started using. And then a few years, about 5 years ago, I also experienced a very significant concussion, which is what my vision-related disability stemmed from. So all of this has shaped the way I think about my work and the research questions I've been asking, in part shaped by my own personal experiences. And I just think that's important to call out kind of in the way I go through those. The research and the personal experience are in dialogue with each other. And the last thing I'll point to is like some of the public policy and advocacy and activism work. And again, I really feel like the more I'm spending time in communities, the more time I'm spending doing this work, it's hard not to then take action in some way based on that. And so that's kind of been the arc of the journey so far. Right, I can look at all these different devices. Let's see if I can. Okay. So I want to talk just a little bit about this concept of alignment and the way I think about this. Just a couple of theory slides that you can get a sense of how I'm grounding my work conceptually. And so are any of you familiar with Donald Norman's work in the design of everyday things? Some nodding. So if not, it's from a human factors engineering perspective or design perspective, it's considered one of the foundational texts. And Donald Norman had created this triad that you can see on the bottom left here. And the idea here is that as a designer, our job is to try to create, right? We have sometimes a conceptual model in our head of what we're trying to design. And our goal is to create a system, and ideally a system image, right? So what the user is interacting with that communicates our conceptual model to the designer. So if we do it really well, if we interact as a user with the system image, we understand the designer's conceptual model accurately. Okay. And so the user develops their mental model of the system by that interaction. So then where the dissonance can happen, right, is then the user will compare it, whatever they've come up with how the mental model of what the system is, with their own work system, where you can think about their everyday lives, their everyday routines, their cultural beliefs, all of these things, and decide, right, if that is fit or aligned with what they actually need. So it's a very simple example. If you think about a system that we're designing to create, to collect family health history, right? You might have a designer who's come up with a technology that's asking questions about grandparents and parents and aunts and uncles. And as a user, you would develop a mental model that the designer is asking me questions about blood relations. All right, and so you might have a very accurate understanding of that, but your own conceptualization of family might be different, right? You might think of fictive kin or chosen family, and we know that those relationships also shape your health and well-being. And so that's where we say, right, there isn't that alignment, even though you understand what the designer's, intent was. And so I talk a lot about, there's a fair amount of my work that really focuses on understanding the user's work system, with the idea that ideally, right, goes back and informs the designer's conceptual model, and that's where we're starting, with that really deep understanding of a user's work system. Okay, so what do I mean by work system? So again, this is from human factors engineering. What does it mean to operationalize the idea of a work system? So you can think about a person. So you look at this little triangle in the middle here. It's a person who's trying to accomplish some tasks, interacting with certain tools and technologies. And that triad is embedded in several different, right, contextual spaces. So embedded in a physical context, in a social context, in an organizational context. And then that in turn, right, all of these things are interacting with one another. And that's the user's work system. That's what we're trying to understand. And so if we're going to introduce a new technology into this as, right, informaticians, right, what kind of alignment are we creating with the other elements of the work system? Or if we're shifting it in some way, right, do we need to shift other aspects of the system to still create that alignment? So you're not, right, introducing more workarounds or introducing more cognitive burden or physical burden or things like that. So briefly, like this whole space is what we've defined as the field of patient ergonomics. And the term patient, I think we all struggle with that term, right? In the context of healthcare, that we're talking about people more broadly than patients. We're talking about people specifically if we're talking about doing work that's focused on health and well-being in the disability context, right? Not trying to medicalize it. So with the caveat that, right, terminology is a little challenging here, we call this space patient ergonomics. And the idea is that we're taking principles and approaches from human factors and ergonomics and synthesizing that with some other approaches to say, can we use some of these techniques that we've developed in the context of other settings and adapt them and adopt them so that we can use them to better design the work that patients perform. And if we think about, so then this is a concept of patient work. And if we're talking about patient work, that can be anything from taking medications to, so I haven't driven in a decade. So for me, anytime I'm going to an appointment, right, there's the work of, okay, I need to coordinate transportation. Is that paratransit? Is that a family? Is that a friend doing that? Yesterday we were at dinner and I have on my phone a list of my 40 food allergies. So it's the process of working with, right, the wait staff to say, okay, what can I eat? And she came back and marked things on the menu for me, and it's that negotiation. So all that is part of, right, patient work. Okay. So in the context of like this broader kind of conceptual space, I work with multiple communities, sometimes as an ally and sometimes as a community member. In the context of disability work, I see myself as a community member. And that's what we're going to dig into today, of course. But I also always want to point out that the disability work is also working in these other health disparity spaces. Okay, so, right, certain racial and ethnic minority groups are overrepresented in the disability community. Those who are living in rural communities, right, disabilities also overrepresented in these spaces. So I always say when we're talking about disability, we're also talking about health disparity more broadly, just right from the nature of disability. So some of these statistics I'm sure are familiar to all of you, but I think of the rationale for this work as having ethical, legal, and design, right, rationales or imperatives associated with them. So this is the ethical in terms of talking about the actual disparities that exist. The first two are related to the healthcare system in particular. The last two, the broader social determinants of health. And of course, this is just two examples. We know there's a wealth of examples. But of course, all of these lead to disparities in health outcomes. So thinking about from an ethical perspective, our rationale for needing to bring more attention to this work. And of course, NIH has started to do that. And that's great, but there's still a really long ways to go from that perspective. The next is from a legal imperative. So there's lots of legislation that's around this space. So of course, the Rehabilitation Act, right, that persons with disabilities must have equal opportunity to receive program benefits and services. And then also Section 508, that's right, part of the 1998 amendment to the Rehabilitation Act that requires federal agencies to give disabled employees and members of public access to information, right, with comparable access that's available to others. So that's one, right? The ADA has, right, similar philosophy in terms of full and equal access both to public and private healthcare services and to facilities. And then the Affordable Care Act that's focused, right, specifically also on electronic and information technology and accessibility. So all that said, right, things like the web content accessibility guidelines, they define how, right, begin to define how to make web content accessible to people with disabilities. Yet we know that about 90, I think what the statistics like 97% of the top 1 million home pages of websites are still inaccessible. And so we think about this, right? And this is of course because of the way all enforcement happens here is through, right, legal action, right? There's no other enforcement mechanism. That it's really on us as informaticians, as designers, to take this, in some ways, the burden upon ourselves to take the responsibility to be proactive, because there is no real great mechanism beyond that to ensure that the technologies we're designing are accessible. The other thing I like to point out here, though, is things like the web content accessibility guidelines are really about usability, right? They're not about understanding, do people with disabilities perform work in a different way, right? Are their needs for functionality different or, right, more or broader than the technology we may be designing for non-disabled people? And so these guidelines are really important, but they focus on the usability and accessibility space, not the usefulness space. And so again, that's part of our work, and back to this idea of understanding the work system, why it's so important to do this engaged work with the community to understand broader needs and not just focus on taking technology we've designed in other contexts and adapting it for the disability community. Okay, and then last is a design imperative, and I know you've talked some about universal design already, so I'm not going to go into this in a lot of detail, but basically, right, designing for everyone is just good design, just from that basic philosophical standpoint. But of course, universal design comes out of the disability rights movement. And you think about this as if you're designing focus on disability, you're also designing for people, right, who may find themselves having accessibility needs in a particular moment. So if you think about something like a phone, right, you might, so I have limited dexterity in my hands and a limited ability to engage with my technology with a touch screen. So it's better for me if there's bigger buttons, for example, right? It's a larger target. But that's also helpful if your hands are really cold, or also helpful if you're multitasking. So, right, just as a very simple example that designing for disability is also designing for people, right, in other circumstances and other conditions where they might also have accessibility needs. Okay, so with that kind of broader overview, I'm going to turn to focus on some work, a couple of empirical studies that I've done in this space of looking at people's social networks and caregiving networks. And you can think about this as focus, well, I'll be talking some about usability because that was part of the work, but also on this idea of how is work currently performed? What are people's rationales for the ways that they're engaging with their social networks and caregiving networks? And what do we learn from that for the types of technologies that might be helpful for us to think about designing? Okay, so I'm going to talk about social networks and caregiving networks and how I'm conceptualizing these and thinking about them. But to begin with, across both of these, it's about thinking about care management as a socially embedded phenomenon. Right? We talk about words like self-management, but instead of thinking about a person in isolation performing their own care, what does it actually mean to be doing this, and to be doing this in a way that, right, we're really acknowledging the interdependence that it, right, underlies how we engage in care management. So for the social network, I've had a series of studies that builds off this conceptualization of a social network. But the way I elicit social networks from those I'm engaging with is I create, right, I give people these 3 concentric circles with the word you in the middle. And then I start with questions like, to fill in the first circle, think about people to whom you feel so close that it's hard to imagine life without them. And then we work out from there for different layers of affect. So it's really an affect-based social network. And a lot of the series of studies I've done, and I'm going to talk about one of them, has been about just understanding with whom does health information get communicated? Why does that happen? In what context does it happen? What technologies are people using? Is it in person? Is it technology mediated? Is it right through social media? And trying to understand the rationales behind it. And I can go down that rabbit hole for a while. But the idea here is not everybody who you're communicating with about health information is necessarily a part of your caregiving network. There might be all kinds of reasons. You might need to, right, communicate to employer for something. You might need to communicate, and we'll talk about this in the disability context. You might be communicating to be an advocate, right? Like I communicate a lot of my health information to you in the context, right? Not part of my caregiving network, but I'm communicating it to you for another purpose. And so how do we think about making health information available and accessible to people in a way that they can share it in the ways that they want to share it, given that we don't have a lot of tools and technologies to do that. We have some limited things like MyChart, we can give somebody proxy access, for example. It's hard to do a lot of granular sharing with the technologies that we currently have. So caregiving networks, on the other hand, think about this as a collection of people who provide caregiving resources, provide information, actually engage in helping manage somebody's health. And usually think of caregiving networks as people who are engaged at least monthly in this type of process. So you might have someone, so I'm going to talk about children with medical complexity. So you might have a child who has a primary caregiver who's often a parent or a legal guardian, but they're surrounded by others who also may serve a role, and we think of those as, right, secondary caregivers in this context. So I'm going to first talk about I don't think we shared this paper, so I'm going to go into some detail about this one study. So this is a paper. This part is a paper that was published in JAMIA just earlier this year. And this was, we were trying to think about designing for caregiving networks and using the case study of children with medical complexity. So this is actually 2 studies. We were doing a secondary analysis of a study that we did out of the University of Virginia. So it's the Mid-Atlantic study that you'll see, and then a study in the Midwest at the University of Wisconsin with a collaborator of mine, Nicole Werner. So we wanted to think about, again, conceptualizing caregiving as a network phenomenon. And the idea is, right, that we were able to do a secondary analysis because both of these studies were grounded in that theoretical framework I presented earlier with the idea of a work system. And so the way that we're eliciting what a caregiving network looks like, and right, the different dimensions of how, right, that experience is for people, trying to understand everything from the physical context, right? What does the home itself look like? I shared that paper with all of you about the home personas that came out of that, right? Trying to understand these different contexts and trying to build from there. So we had, because these 2 studies were done independently, and then we brought them together, we had a few different operationalizations of children with medical complexity. But broadly, you can think about this as children who experience several and severe chronic health conditions. They also experience functional limitations, and they rely largely or sometimes entirely on a network of both formal and informal caregivers, right, to have safe and high quality care. So you can see there's a couple different ways in terms of operationalizing this, but broadly speaking, that's, you know, kind of the umbrella. Okay, so we had 2 different studies. The first study was had interviews with primary caregivers, And it was really, the study was originally focused on what are the workarounds that are developed by family caregivers in the context of routine care, right? So in the context, right, kind of what would ideal look like, and to be able to accomplish the goals that they have for their children, what types of workarounds do they have to create, right? Different kind of processes just to make sure the child is getting the care they need. And then in this study was also observations where the parents were demonstrating the type of care they provide for their kids. So both observations and interviews. The second study were interviews with primary caregivers, but also with members of their social network. So in the second study, we were looking at interviewing parents about the kind of everyday types of routines that they have around their children with medical complexity, and looking at everything from the types of equipment that they're using to the appointments that they have to, right, kind of routine care that needs to happen at home or therapies that need to happen at home. But then also asking them to identify those secondary caregivers and then going and interviewing those secondary caregivers as well to understand from their perspective, how are they engaged in supporting children, the children. So the interviews were between 90 minutes and 2 hours in length. And this was an inductive approach to qualitative content analysis. I will say the other important thing to point out here is our team is really highly, it's both interdisciplinary and also like kind of non-disciplinary, but the lived experience part of it, where we had those of us who are informaticians and human factors, but also people from public health, clinicians from nursing and physicians who work with children with medical complexity, but then also patient and parent advocates and people who are former children with medical complexity now are adults, right? Also informing the way that these studies were conducted. So this is like, you don't have to try to read this, but if you look at the paper, if you do pull up the paper, this was a visual synthesis of the 8 themes that came out of this. And I'm going to go through the themes and talk you through them. But this was, we were trying to find a way to visually represent how these themes interrelate. Okay, so the first theme is that engaging the caregiving network requires, we said, significant administrative work. For those of you who are familiar with some of the other language around patient work, you could call this articulation work. So it's the idea of, you think of patient work sometimes as, right, you think of illness work, the work you have to do to actually manage your health, or the everyday life work that you might do, right? Like meal prepping that might not have anything necessarily to do with the health condition, or it might. But articulation work is all the coordination that happens between the different tasks you have to perform. So here, this was about, for example, like if you have like an informal caregiving network and you have 4 or 5 people involved, how do you actually standardize record keeping? Right, so if different people are feeding the children or the child or administering medication, right, who's keeping track of that? How are you keeping track of it? Is this, right, so people come with a wide range of strategies to do this. So that's one example of what this looks like. I'm not going to read through all the quotes, but there's quotes up there that kind of illustrate what this is like. Actually, I'm going to read a few of them just in case that's helpful in terms of access for some people. So this says, I am constantly, almost to a fault. I'm always researching and finding. I try to stay ahead of the next step and what's coming next, and try to be prepared just in terms of how we're going to deal with it, changes to the child's needs. So this is a parent who's talking about trying to stay one step ahead of how are the child's needs evolving, and what does everybody else in the caregiving network need to know, and how are they going to be able to communicate that information ahead of time and kind of stay ahead of the changes that are happening for the child. The second theme is that primary caregivers manage dynamic caregiving network memberships. So this is the conversations about how these networks are rarely constant, because we're talking about both family and friends, and also talking about home health aides, right, and nurses who come in, and sometimes therapists who come into the home. And this is constantly dynamic. So there's a lot of coordination that happens, but there's also physical and emotional burnout that can happen in terms of for secondary caregivers. There's people who move away. There's, right, family and friend conflict that may have nothing to do with the actual caregiving. That means people are coming and leaving. So it's all the kind of dynamic management that happens around the relational, but that then impacts, right, the experience of caring for the child. The third theme is about that the methods for communication are shaped by the caregiving network size and frequency. And so the way the collaborations and interactions happen is shaped by how large the network is. And that here again, if you have a larger network, it may be more formal methods. So you might have a whiteboard, right? We saw some parents who have a whiteboard in their house where they're trying to keep track of things. You might have a digital calendar where everybody's, right, the people, when different people are caring for the child is indicated there. You might have a binder, right, with different things that people are putting pages in and out of, right, in a less digital way. But you're trying to understand, right, what does that workflow look like and how is that shaped? With those who we would call maybe more informal or a smaller network is maybe just one other person. And that was not as formal in terms of the methods. And so this is the quote here, where it's, I'll tell her, the mother, the primary caregiver, right away. And this is like one of the care network members talking. I'll reinforce it a few times, like remind her and stuff. She's pretty consistent with being around. Like we see her pretty much every day. So regardless of either she'll come over here or I'll stop by there. So there's not a formal documentation system, right? This is really happening from the relational, right? And it's much, in some ways it's dynamic and very responsive because the people, they're constantly in communication, as opposed to having it external, right, to that dyadic interaction. The fourth theme here is that primary caregivers help the caregiving network adapt to evolving communication and coordination needs. And this gets a little bit back to, right, as a child's needs evolve, the communication methods, the documentation methods, and all of that evolve. And really the primary caregiver, once again, is managing all of that. And right, they're changing their processes as the child's needs evolve, and they're changing their processes for then engaging with that broader caregiving network. Okay, so fifth theme is a caregiving network role delegation depends on the personal, basically the comfort, right, of the parent to be able to, right, give somebody else in the caregiving network certain tasks. It also depends on how comfortable the network member is. So sometimes somebody may know how to do something kind of in theory or been trained, but because the stakes feel so high, isn't comfortable being the one to administer medication to a child, for example, or to administer, right, the liquid food formula, which is what this quote is about, to the child. So the parent is negotiating that too. So sometimes it's hard to find assistance because even if you have people around who in theory are willing, just that level of comfort and trust isn't there. And sometimes somebody with themselves, right, and being able to do this well. And sometimes it's also for agency regulation. So sometimes certain home health aides are not allowed to administer medication, for example, right? So even if somebody else is around, a parent may have to build their routine and think about how they're going to do this in the context of what somebody else's limitations are, whether that's legal limitations or whether that is in terms of just comfort. Sixth theme is that primary caregivers fear negative judgment when asking for support from caregiving networks. So here's the quote is, I don't feel like it's fair for me to go ask people to help me, babysit him, or just come over and help. I don't like to ask people for help because I don't want people thinking I can't handle it, or people thinking I'm not strong enough to do it, or I'm trying to get sympathy or something. I don't know. I just don't like asking for help. So this is, right, the kind of, again, from a patient work, we talk about biographical work or, right, sentiment work, the kind of the relational, the ways that you're thinking about yourself, your own identity, and right, how that then goes with what right, the ways you're going to engage others. Sometimes it's really about not wanting to add burden or stress to someone else too. So it's like the kind of self-reflection, but also, right, the other directed way of thinking about this. Okay, just two more things. So seventh theme is a primary caregiver's balance, the mixed usefulness of community caregiving support. So if we think about online health communities, there was a lot of conversation here about, of course, it's helpful, right, to learn from other families' experiences, other parents' experiences. But there was a lot of conversation as well in terms of that sometimes families can feel defined by the fact that there is a child in their family who's medically complex, and the wanting to have the interactions sometimes that are not focused on that. So how do you engage with others and other families, the children with medical complexity, but not always focusing on the deeply emotional part of it or the deeply, right, hard part about the logistics and the coordination and that part of the sharing. So thinking about if you're building an online health community, how do you make it so that, right, somebody can choose when and if they're, what type of information they want to engage with, what type of conversations they want to be a part of, and not just like seeing the conversations and choosing, but how can you use, right, more like machine learning and say, okay, these are the types of conversations, or right, these are the kinds of words I don't want to have right now. Like I'm not in an emotional space to be able to engage with that. And the last thing here is that primary caregivers weigh trade-offs and face paradoxes. that inhibit optimized caregiving network operation. So sometimes there's like conversation, right? Sometimes you're working to pay for hired help, and that help allows you to work, right? So it's kind of, right, it's balancing these tensions in terms of the decision making. Okay, so I thought I'd just pull out just a couple, just 3 key takeaways. There's a lot there. So the first is this need to support the continuity of care by supporting, right, all the ways that this process is so dynamic, right? It's not that there's somebody comes up with a caregiving plan and one caregiving network, and then you're just trying to support something that's fairly static or stable over time. But for a lot of families, this is very dynamic. And so how do you help build trust, right? How do you help manage like membership of who's in this network and what information they're given access to, so it's not, right, information overload. And how are you responsive to the fact that a child's needs are also evolving over time, right? And providing the right information at the right time to the right person in that context. To me, I'm going to move to the third one, because I think this is really tied into this idea of trying to minimize the burden of repetitive tasks. So the repetitive task of training, right, and onboarding new care members of the caregiving network, the idea of how do you, the searching for others who can come in and help. So sometimes families talked about it's helpful to know other families with children with medical complexity, because maybe they've identified somebody who can come in and help, and maybe that person is willing to come and help my child. So how do you facilitate those, building those connections around people? And then this idea of invisible work. I don't know if you're all familiar with this, but right, but this idea of things that are unseen or unvalued. And so a lot of this work we talked about, right, like the articulation work that parents are doing to standardize charting or documentation, all that coordination work, for example. How do you make that visible to clinicians? How do you make some of the things that we're going to talk about in the workshop, right, about like what somebody's home layout looks like and how that shapes the way they can provide care? How do you make that visible to clinicians so that part of the shared decision making and care plan, right, the formulation of that care plan jointly takes into account all those contextual factors. So both the invisible work that's happening, but what we'd also call the invisible work system, right? Parts of the different social environments, physical environments that might not be seen by clinicians, but that are really important to creating care plans that support a family and meet them where they are. Check my TK one for you. So I thought I would talk about one other project, but not in quite as much detail. So this one was funded by AHRQ, and this was focused on adults living with a wide range of disabilities, so physical, cognitive, sensory, and mental health related. And here, this was focused on this conceptualization I talked about earlier about the social network. And so I was interested, there was a qualitative part of this, which I'll get into, that was really focused on understanding, eliciting people's social networks. And we engaged with people I have diagnoses. I always struggle with like disability work about diagnoses versus, right, like self-identification, but just, right, so you know, there's over 80 different diagnoses represented in this group. So these were people who engaged with us for a period of 2 years. So the first part was doing these interviews and eliciting people's social networks. And I was, again, just trying to understand people's everyday lives as they're engaging social networks. The second part was what we call task analysis, which is a very traditional industrial engineering method of actually asking somebody to take technologies that exist and walking them through it in a very structured way. So we were doing this with 3 technologies that had been built to support how people communicate with others in their social networks. So we looked at MyChart, we looked at the time at Microsoft Health Vault, and then we also looked at Caring Bridge. So they're technologies that are differently created, so more of a blog format versus really sharing, right, what's in your clinical, right, in your clinical record, versus Microsoft Health Vault at the time was an untethered PHR, so you could put in your information from across clinic settings and had a lot more granularity built into it in terms of, right, what information you might share. And then, so this was, we actually went to people's homes and kind of took our lab with us and, right, and kind of again, back to meeting people where they are, and did this task analysis where we'd ask people to engage in certain tasks along the way and watch the experience of it, right, usability and accessibility with these tools and technologies. And then we asked people to bring the technologies home. And so this was ideas, that first part is really focused on that person, tool, technology, task triad, and kind of a more of a, right, in a very like several hour period. here we were asking at the end when people brought the technologies home and stayed and used them for 2 weeks is how does that experience then shape by people's social networks and the physical environment that they're in and everything else. So trying to understand how context, the interplay between the context and that triad. And then lastly, we had more design workshops where we're trying to orient it towards future design. So right, how might we ideate about what these technologies could look like moving forward? So yeah, so this was 55 individuals. And we're doing maximum variance sampling across a lot of different demographic characteristics and experiences. And we were recruiting from 2 centers for independent living and 2 rehabilitation hospitals as our main recruitment sites, but then a lot of also nonprofits. Okay, so again, I'm just going to pull out 3 things. I'm not going to go into all the results because there's a lot there to unpack. But for that first part of it with the interviews, again, I talked about this was a 3rd study in a series of studies where we were looking at social networks, and the others were focused on people living with type 2 diabetes. There were different rationales that came out of that, and I'm happy to share those papers if anyone's interested. And this analysis, I was really looking at how do people actually talk explicitly about disability in the context of why they have certain rationales. And so those rationales fell under 4 broad themes of support, advocacy, disclosure, and logistics. But the thing I wanted to point out here is I talked briefly about advocacy, and advocacy was one that came up quite a bit where people were talking about advocating for themselves, or disclosing health information as a way to advocate for themselves and their own needs, but also to advocate for the broader disability community. And so this was a rationale was very unique in some ways to the disability community that we hadn't seen in some of the other studies. And again, I'm happy to go into this if everyone has questions, if anyone has questions about it. The second one, this gets to the second bullet point here is related really to that task analysis and people bringing the technologies home. So we found, again, disability specific challenges with usability and usefulness, but that were really across, how you might design content for technology, how you might design functionality, the user interface, and the tech platform itself. I thought I would show a video, but I don't know if I'm not doing great on time. I know, so I'm trying to leave a little time for Q&A. It's a short video. Yeah, I'm gonna play that. Yeah.
Just hit skip for me.
Okay, right, go. But I just thought I'd show you one interaction from this task analysis so you could see what this looked like.
A blind participant uses the typing feedback function to type a message within the application. The participant expressed confusion in distinguishing between which keys were read aloud versus which were typed. They further reflected on the difficulty in finding the correct letters due to how close together the keyboard letters are.
So that second E word looks like a little different than that you typed it.
So basically what we were trying to do from a method standpoint, we were both videotaping this, we're doing screen capture, but also having another video camera to see basically the interaction between the person, and the technology itself. So there's a lot of findings that came out of here. So again, I'll just touch on a few things briefly. So of course we had work related to voiceover, and one of the technologies at the time, the device we were using, so while this touch screen goes to the edge of my phone, the touch screen in that one, there was a part that was inactive in terms of the display. So that came up over and over again, where it's not voiceover isn't working, but it's not that it wasn't working as intended. It was working as intended, but there was no way to have haptic feedback that you are at the part of the screen where there is no responsiveness from the screen. And so, so then one of the things that we ended up bringing is basically a way to create an edge, so there was a haptic feedback. Another thing that came up in terms of functionality, so I use a lot of dictation-based software. I use a screen reader just because of my own vision-related disabilities. So the idea of being able to use something like Siri to input things if you're trying to chart or trying to track your, whatever metric you're trying to track over time, can you be able to put input in through Siri and then have the graphs or whatever generated in that way. And the last thing I'm going to talk about, I feel like I'm doing a little bit of a whirlwind here, is related to designing with the disability community. So here, this is another paper that was also published in JAMIA a couple of years ago, 2 years ago now. And this was, we were drawing on these 2 studies, but also several other studies we've done in partnership with the disability community, but also from a lot of the advocacy work that we've done as well. And so across physical, cognitive, sensory, and mental health related disabilities, what can, right, human-centered design, user-centered design, co-design, right, what do these processes look like, and what types of things, if you were just starting out in this space, what types of things you might want to keep in mind in trying to do this type of work. So the first step we talked about is just understanding the broader disability context. I don't think this is disability specific. I think this is working with any new community, right? That this is so important to do the background work, to have that depth of knowledge when you're entering this space. So respecting things like historical context, right? Health research, of technology-based research in this community. The experience of those, right? The disability community is not a monolith. So understanding, right, the differences across the community, understanding the experiences of people with intersecting identities, right? So that all of these are different experiences, and it's really important to have that breadth of knowledge. Becoming familiar with contemporary debates, as a very simple example that you've all been having these conversations around disability, so it's probably not novel, but this idea just of language, right? Do we use person first language? Do we use identity first language? Understanding both, right, what the debate is in terms of, right, what do you say, right, person with disability or disabled person, and when is what appropriate, and the fact that different sub-communities have different thoughts about that, right? Just understanding that when you're walking into the space. And then understanding the relative appropriateness of different models. I mean, I just have medical and social model here, but there's lots of models of disability. But again, becoming familiar with the different ways people are conceptualizing that. Are you all familiar with medical social model? Is that, yeah. That's this. I don't want to get into things that you already know. All right. So the second is about, right, creating the real long-standing partnerships with the community. And of course, this takes time and is important. And then, ways to do this, of course, are also collaborating with people who built long trusted partnerships that you have a trusting relationship with, right, as a way to also get started in this space. But I think about, right, just the idea of like the nothing about us without us that we always talk about in the context of disability. This is so important in that context, and that the community-based participatory research, or right from informatics standpoint, we talk about co-design or participatory design, right, is really embedded in that philosophy and the importance of that. So here, the idea of developing strong relationship with community organizations has been really important for me. And again, because the disability community is so broad, it's often many organizations you have to develop partnerships with if you're doing cross-disability work, because so many of our organizations are diagnosis specific or disability specific. So it's building those coalitions is really important. And then knowing the organizations that aren't, like Centers for Independent Living, if you have, right, like if you're able to partner with Center for Independent Living that is cross-disability, right, that they are also a nice way to then connect you to other specific organizations. So starting there. So working with community organizations or, right, disabled people throughout the research process, starting with understanding the priorities of the community. I think this has been really important for me. I always think of my own humbling over time, right, starting with ideas in my head that I think are important to pursue versus, right, starting just with conversations with the community and learning, right, what are people's priorities in the context of their own challenges that they're experiencing. And then assembling a team that includes disabled people. Disabled people are, like, right, we're all very underrepresented in research, but that brings another perspective, just, right, as it always does, to have a team member who also identifies. So the intentionally engaged diverse sample, the first point I want to make is just because the concept of disability, right, it's so multidimensional, the importance of thinking about this when you're thinking about, right, who to engage. If you talk about engaging the disability community, this is about diagnosis, but it's also about, right, you can have the same diagnosis and have a lot of different experiences about how that diagnosis manifests in terms of everyday life. And this is not just in terms of symptoms, but also in terms of, right, what your experience is in the context of that broader work system. Again, the same disability have a very different lived experience. So thinking about that. And then thinking about whether or not somebody has the identity of being disabled is also a really important thing to think about. Because if you're engaging, not everybody who has functional limitations identifies as disabled, and actually many people do not. And thinking about that also shapes somebody's lived experience and how they might engage with you, and thinking about, right, what their needs are and what they might attribute those needs to. Just in terms of developing accessible recruitment materials, thinking about, again, like, how do you create things that are multimodal? So audio-based recruitment materials that are right text-based in plain language, right? So making it as easy to understand as possible. And then right things like large font, right? So again, just think again about in ways that I think sometimes we don't always think about. We're thinking about cross disability, making sure they're accessible in that broader way. I'm just gonna try to get through just a couple more here. Creating responsive and accommodating study procedures. This has been a lot of learning for us, just again in partnership. So I'm going to talk about the second one for just a minute. So collecting information early on about how people want to engage with you, and right, starting with scheduling and informed consent and all the way through. And for us, this has really set the tone that this is collaborative, acknowledging that people's accommodation needs are going to change over time and over the course, particularly these projects are 2 years long, that we're trying to set up this tone of please, let us know how your needs are changing. We're going to do our best to be responsive. This is about where we meet people. So we do a lot of work in people's homes because it's more accessible for them, or in public libraries, instead of asking people to come to us in a lab-based setting, for example, when we're doing that type of work, because that can be really challenging for all kinds of reasons. And then to come prepared with alternative approaches to collecting data. So we think about when we sent people home with those technologies for 2 weeks, right, giving, of course, options of things like a phone or an iPad, but also thinking about how are people going to give us information over time, right, over the 2-week period. So for some people, it was, I need you to call me, right, every day. And that's how I'm going to be able to tell you what my experience was. But some people are like, it's easier for me just to do a voice memo and send it to you. And for others, it's, can we have a text exchange? Right, so just different modes of it, and thinking, right, again, along with your participants about how do we make this as accessible as possible. And then lastly, just this idea of building foundations for future work. I think we all, right, as informaticians have a role to play in advocacy in this space. So one of this is just to recognize, right, and consistently recognize, even if we're doing work that's not disability focused, that it is inclusive for the disability community. So all these questions about accessibility, usability, and usefulness are not just when we're doing disability specific work, but they're always relevant, just right as other people's needs are, and being really attentive to that. If you're writing a grant or a proposal that has something nothing to do with disability, right, still putting in your budget funds for accommodations, for example, right, this forms a part of any work that we're doing. There's also work for advocating for clearer and more comprehensive standards. So even thinking about the web content accessibility guidelines, right, even as there have been multiple iterations, it's still early days, that though they're not really very clear, they're not enforceable, that there's a lot of work to be done there, and right, all of the different research we do can help advocate for those better standards. And then the importance of monitoring differential and unintended consequences. So we thought about this, I mean, even the context of telehealth is sometimes the example I like to give, that there is fear within the disability community that, right, if it's easier for clinicians to work with disabled people when it's remote and they don't have to think about the accommodations in the clinic, because most clinical spaces are not accessible, does that mean it will be a form of cost containment, a form of convenience to encourage disabled people to seek care online, as opposed to, right, trying to create in-person accessible spaces? So for all of us, is we're doing this work and trying to create more access, to create, right, equitable solutions, also being really attentive to unintended consequences. With that, let's have acknowledgements and I'll end there. Thank you.
I think we have a couple minutes for questions, so we can start questions in the room, and I will also come and look on Zoom to see. Bettina,
I can go for it. Yeah, thank you so much for this inspiring work. My question is, if you have any unexpected findings from your studies, and like, for example, any caregiving experience difference between the Midwest and Mid-Atlantic regions, and how these might influence future research?
Yeah, and it's a good question. I wouldn't say, we didn't see like really distinct differences between the Mid-Atlantic and Midwest. Part of that, I think, is the two cities that we were doing it in, so Madison and Charlottesville is like the main that are surrounded by more rural communities. Even though it's Midwest and Mid-Atlantic have some similarities, I think it'd be very different to do it right in New York City, right, with there's very different context for that work. So we didn't see any geographic differences, I would say. Yeah.
So my question is, I mean, some of these children might have been really young, so it's very hard to like interview them, but maybe if they're some children that are maybe reaching their young teens,
Mhm.
is there a push or is there an interest to also take into account how they feel and they interact with their caregiving network and how that actually influences, I don't know, that's okay, how it influences like the interaction between the caregivers?
Yeah, that's such a great question. And so we have a current grant that we're working on right now that does that. So we're interviewing both parents and children as a way to understand those multiple perspectives. So a lot of the children in these studies were much younger, just from the clinics we were recruiting from, or like kids that were like under 5 years old, but now working very specifically to recruit children with medical complexity who are older. And also that particular project is focused on those who are holding 2 or more marginalized identities as well, because, you know, in both of those first studies focused on children with medical complexity, we didn't have as much representation from racial and ethnic minorities, for example, and from some of the rural communities as we would have wanted. So being very purposeful about our recruitment and trying to understand, you know, just the range of experiences there, but also if people attribute, right, certain things to those particular ways that they're positioned.
A very small follow-up.
Yeah.
So I anticipate like having discussions with these children and specifically trying to understand their perspectives might be really challenging, might be really emotionally intense for some of these children. How do you navigate that? Like you bring in trained professionals who, you know, can handle those kind of questions and conversations with children.
Yeah, that's also a really good question. So yes, right. So our team includes, right, those who provide mental health services, right, as like a part of that, but also it's the conversation with, of course, always, right, with the child, because it's really hard for parents to, and obviously in different ways. And so it's always the option to, you know, this is voluntary, right? Now we're going to talk about this. And so, right, if those are questions you don't feel comfortable talking about now or at all, that's okay. We can circle back to them if you feel up to it. We've definitely done interviews in some of these where it's multiple meeting times. And sometimes it's because it's emotional, and sometimes it's just because, right, in the context, right, there's the care actually needs to happen in that moment for whatever reason. And so you can't do the full hour-and-a-half long interview at once. And that's actually not that uncommon, where you're having part of the conversation and circling back later to the conversation.
Thank you.
I think we have a question from Katie Brown.
Hi, yes. I was curious if you noticed a difference in the importance of themes based on either the age of the children or how long they've had their the diagnosis for their chronic condition, or maybe not a full diagnosis. And then kind of tied to that, for conditions that are either more rare or more well researched, if you saw a difference in themes for those patients as well.
Yeah, it's another good question. So just given the nature of the qualitative work, right, with 20 in one study and 30 in the other, we weren't looking at differences between conditions. We were really trying to understand the experience across all of the conditions. It's just not a large enough sample size to make meaningful conclusions there. But I absolutely think, right, as like a next step, it would be really nice to done a lot of work to use the qualitative work to then create, right, a survey or other quantitative measures that we can then use to understand those types of distinctions. So I think it's a really important question, but not one that we could answer, based on just the methods for this particular study.
Yeah, makes sense.
And we're right at 2. So I think, thank you very much to everybody on Zoom. Thank you again, Dr. Valdez.
I also want to thank all the people that the students and helping with all the organization here, Pooja, Para, and Adrian. And we're all going to be also, I know, in the working group, but thank you very much. And of course, Dr. Valdez, that's wonderful. So thank you.
Thank you
Thanks,
all.
everyone.
And then